Good afternoon, everyone. I'm Stephanie Maselli. I'm a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us today for our recently released report, Meeting the Challenge of Caring for Persons Living with Dementia and Their Care Partners and Caregivers. To read the full report, you can visit nationalacademies.org/dementiacare. The slides and recording of this webinar will be available on that page as well within the next few days. And for those of you who are not familiar with us, the National Academies of Sciences, Engineering, and Medicine are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the entire committee, and they must undergo external peer review before they're released, as did this report. I have with me today several members of the committee to discuss the report's findings and recommendations. But before I introduce them, just a few reminders. This webinar will last 1 hour. We'll start with a presentation summarizing the report by our committee members, and then we'll open it up to any questions that you may have. If you want to submit a question, you could simply click the Q&A button on the bottom of your screen. And should you have any technical issues during this webinar, you can contact Zoom technical support at 1-888-799-9666 and select option 2. Now I'd like to introduce the members of the committee that wrote the report who are joining us today. We have our committee chair, Eric Larson, who is senior investigator at Kaiser Permanente Washington Health Research Institute. We have Xin-Shi Dong, who's a practicing geriatrician and the director of the Institute for Health at Rutgers University. We have Rebecca Hubbard, who's a professor of biostatistics at the University of Pennsylvania's Perelman School of Medicine, and Robin Stone, Senior Vice President for Research at Leading Age and co-director of the Leading Age LTSS Center at UMass Boston. And with that, I'd like to turn it over to Dr. Larson to kickstart the presentation.
Thanks, Stephanie, and thanks to all of you who have joined us. It's a fabulous vote of interest to have so many of you on the presentation. And I say good morning because I'm in Seattle and it's still morning. I'm presenting this with 3 colleagues on the committee on behalf of the entire committee. And I would call attention to this second part of the title, A Way Forward, and hope that as you listen to this presentation and then go and read the report, you'll get some sense of optimism and a sense that there is a way forward in meeting the challenge of caring for persons living with dementia. Next slide, please. This is our charge to assess available evidence and to inform decision-making and identify research gaps. And I note that the last 2 bullets are why we put this title, A Way Forward. I hope that as the day and as this report gets circulated, you'll hear more about how this way forward will be identified. Next slide, please. This is our committee. The 4 of us are presenting on behalf of this amazing group of people. We started our work back in the summer of 2018, so we've been together for quite a while and literally went from in-person meetings to very effective virtual meetings. And throughout the process, we had amazingly strong support from the National Academies staff. Next slide. The model is described in this slide. Phase 1 involved gathering to talk about how the AHRQ systematic review would be carried forward. That resulted in a letter report. And then phase 2 was once the report came out, we used that report as a primary source of evidence. And we also had supplemental sources that you'll hear about. And importantly, I want to make a point that we had a very constructive and optimistic, I would say, public workshops and sessions, and had an advisory group that helped the committee members immensely in terms of how our report finally made it to the light of day, which is what is happening today. Next slide, please. And again, the verbiage, I just want to highlight, moving is the operative term here. Moving towards, meaning moving for a way forward with our goal of providing outstanding and person-centered care for persons living with dementia and those providing their care. Next slide. This is some of the ideas that we heard from our public members, as well as public persons who contributed to the deliberations of the committee. This notion of support for leading meaningful and rewarding life, maintaining independence and agency, enjoying activities of interest, sustaining social relationships, and connecting to familiar environments and communities. And we know how hard that has been since the pandemic occurred. And to do this, to live well with dementia, people do need care, services, and supports, and that reflect their values and preferences, build on their strengths and abilities, promote well-being, and address needs that evolve as cognitive impairment deepens. This is the essence of what I think is going to be valuable over time about our report. Next slide. This, I'm sure, is reflective of why there are so many of you joining our report today. The situation is urgent, in part because the number of people affected with dementia is large, and even more, the number of people who provide care for those individuals. And although there are examples of very, very good care being provided in places, many persons do not have their care needs met. And this is particularly important for those experiencing inequities with regard to underrepresented racial and ethnic minorities and those at the lower end of the income ladder. And again, we've seen this amplified, if you will, since the pandemic. And the final bullet is, again, people are looking for help and looking for interventions that address their needs and preferences. Next slide. So some of the guiding principles that we'll talk about here, and you'll hear throughout this presentation, are on this slide. And I just call into your attention the highlighted areas. This doesn't, the fact that the evidence does not meet the standard of high strength doesn't call into question some fundamental aspects of high quality care that the report outlines. And also the same thing, the guiding principles and core components of care to guide actions are going to be elements that you'll hear about as the presentation goes on. I hope that you'll read about when you have a chance to look at the report. Next slide, please. This is a slide that's taken from the report itself. Again, the guiding principles are critical, and they're on the left side of your screen here. Patient-centeredness, promotion of well-being, respect and dignity, justice, inclusivity, and accessibility and affordability. These principles you'll find throughout the report, and the committee feels uniformly enthusiastic that these should be the guiding principles for the care. And the components of care are listed here. It's a long list, but it's basically not an unfamiliar list of people who are providing care for persons living with dementia. The next slide, and with that, I'm going to turn it over to Robin, who will take it from here.
Thank you very much, Eric. Thank you, everybody, for being with us today. This has been a fantastic experience for me as a member of the Academy, and as someone who straddles a number of different lives. I am a researcher by training. I've spent a lot of my work life in policy work around aging services, including dementia care. And I also work at a provider association. So I am oftentimes really in the real world seeing the pragmatic needs of people who are providing services to persons living with dementia, their caregivers and their care partners every single day. And that balance between assessing the evidence and then making decisions in very complex systems, including the organizations that I work with every single day. In this case, nursing homes, assisted living, adult day providers, home and community-based service providers, home health care organizations. This is extremely complex. And so I think we need to understand that as I go through some of the next slides, if we can move us to the next one. Because of the complexity of the organizations, the individual level, the policy level, and our society in general, because of the complexity that we face in terms of thinking about how do we provide good services, care, and support to persons living with dementia, their family caregivers, care partners, and paid caregivers as well. We really felt that it was important for us to establish a framework for thinking about care interventions. And you can see that there's a block that talks about care interventions for these various individuals, the individual, the caregiver, and the care partner. And then a lot of this work that has been done in our research really has focused on the individual and the family level. But there is also 3 other levels that are essential. And that's why we have highlighted them here, because this is also where we're going to see that there are a lot of gaps. In addition to the individual and family level, these interventions are occurring at the community level. They're occurring at the policy level. All of the different kinds of payment reforms, paid policy, paid leave, even transportation policy have great implications and impact on people living with dementia, their families, and their care partners. And then finally, even at the societal level, we have to really think about that level of care intervention and the impact that that's going to have on the various players and stakeholders that are involved. If we can move to the next slide, please. So this underscores, and our committee really struggled with this. We had an incredible group of people really working through this, thinking about the complexity of the systems, the fact that we have to deal with this at multiple levels. And not only that, but what are the interactions between these different levels? And the fact that the people living with dementia, their care partners and their caregivers are not homogeneous. There's so many different kinds of people who are engaged in this enterprise, and the diversity is essential in terms of how we think about the research that is currently done and will be done in the future, and then the complexity of the interventions themselves. We had to put all of that together and then take a look at the AHRQ systematic review to try to draw some conclusions and figure out where we were going to go from there. So if we can move to the next slide, making decisions about this implementation. You can see right here that there's a number of things that we had to deal with, including the fact that we have insufficient collection and publication of evidence often, and particularly around those 3 levels that I talked about that are not at the individual and family level. Interventions that demonstrate efficacy really need to be tailored because of the heterogeneity of the population. Monitoring and evaluation is so important to thinking about the translation of these interventions to the kinds of worlds that I live in, the providers that I work with every day, as well as the individuals and families. Pragmatic trials and some of the adaptations are going to demonstrate that they're not necessarily effective in real world settings, or in certain contexts, they may be useful in one, but not another. And then we actually have to think about all the different stakeholders who are engaged in this endeavor. So if we move to the next slide, interventions that are ready for implementation with evaluation. So I'm going to give you just a thumbnail sketch of our findings around the AHRQ systematic review. And I want you to underscore what Eric said. This by no means means that we are not ready for a lot of prime time work, and that there is also more work to be done. But the AHRQ review found that, none of the interventions met high strength or moderate evidence of benefit, but that we did identify 2 interventions that were very multifaceted that were supported by low strength evidence. These are really important because they are multifaceted and have great potential for systems change and work at the individual and family level. And they include collaborative care models that really use multidisciplinary teams to integrate medical, social care, and psychosocial approaches to delivering services and supports to persons living with dementia, as well as their family caregivers, partners, and paid caregivers as well. And that they actually had some effect on a number of really important outcomes. And the second model was REACH2, which for those of you who don't know, it's resources for enhancing Alzheimer's caregiver health. That's the fabulous acronym. And that is also a very multifaceted intervention that includes everything from support groups to stress management, to information and education, to role playing. There's a whole panoply of interventions that are built into REACH2. That multifaceted intervention actually improved care partner and caregiver depression. And so these were the 2 of all that we looked at that actually met that low strength evidence, and that we were ready to move forward to the next stage. With that, I'm going to turn it over to Rebecca.
Thank you. Next slide, please. Oh, sorry, this is the right slide. So given the results that Robin just discussed of finding these 2 categories of interventions that showed low strength of evidence for effectiveness, our task was to determine whether or not we felt that these were ready for broad dissemination and implementation. So we gave a lot of thought to this question, and specifically to coming up with a methodology that we could use and feel confident would give us an ability to make a rigorous determination of whether or not these interventions were ready for dissemination and implementation. The approach that we decided to take to this was a 2-step approach. So we decided that the AHRQ review would constitute essentially the first step in this process. And that step represented determining whether or not there was evidence of effectiveness. The AHRQ review was focused very specifically on that question and ensuring that the studies that they included in making a determination about effectiveness of interventions were of the highest methodological rigor. So using the evidence from the AHRQ review on effectiveness, we then went on to the second step, which was to say, for these 2 categories of interventions that were found to be effective, were they ready for dissemination and implementation? And in that step 2, we used a framework called the GRADE Evidence to Decision Framework, which brings in additional information about whether or not these interventions had the additional characteristics of equity, acceptability, feasibility, and considers their resource use. The reason for this 2-step process was, while the AHRQ review was very informative with respect to effectiveness, there was a broad base of literature, additional studies, and other information, for instance, from stakeholder interviews, from the best practice caregiving database and other sources that may not have met their stringent criteria for determining effectiveness of an intervention, but which could help to inform these other characteristics of an intervention, which are equally as important in terms of determining whether or not they're ready for broad dissemination and implementation. So in our 2-step process, we took the 2 categories of interventions that Robin just mentioned, which were found to have low strength evidence for having a benefit. We then evaluated equity, acceptability, feasibility, and resource use by taking a look at additional resources that may not have been included in the AHRQ review. So that constituted conducting reference mining of studies that were included in the AHRQ review, as well as taking a second look at studies that had been identified by the AHRQ review, but didn't meet their inclusion criteria for evaluating effectiveness. So we took a second look at those studies to see whether or not they could be informative with respect to these other characteristics. We also did more literature review ourselves. As I said, consulted the best practice caregiving database and other sources. So bringing these 2 pieces together, the effectiveness as well as the evidence decision framework, we were able to come up with the conclusion as to whether or not these 2 categories of interventions were ready for broad dissemination and implementation. And finally, before moving on, I just wanted to make a note that that methodology which we developed for this specific purpose is distinct from the methodology that we used for determining or identifying what gaps and opportunities exist in the literature base. And I'll talk more about that methodology coming up a little bit later. Next slide, please. And I'll turn it over here to Eric.
Thanks, Rebecca. And I'm going to go through quite a number of slides here talking about the models and leading into the first two recommendations. The first is the collaborative care model. And this is a multiple component model, as Robin said, including coordination, development of plans, case trackings, provider collaborations, and the models operationalize many of these core components that we talked about earlier in that slide of principles. Next slide, please. So we found that there was sufficient evidence with regard to this model leading to improvement in quality of life, some other quality indicators, and emergency benefits, emergency room visits, excuse me. And that if the second part of the slide, there are a number of other individual studies that didn't report consistently, but were a source of optimism, I would say, with regard to persons living with dementia having improved neuropsychiatric symptoms and better nursing home placement outcomes, as well as care partners having better levels of really quality of life and less strain and less depression. And again, the idea of a way forward seems to be suggested by this level of evidence. Next. These other factors around collaborative care models that are worth noting is that they weren't just in one area. They've been studied in multiple and diverse populations. They've been around for other chronic diseases, and they map across the spectrum of disease severity. And although it's been disseminated and used in some ways, there's still quite a ways to go to get some evidence related to acceptability and feasibility, but there is enough evidence there to justify, again, a way forward for this area. Next slide. Now, REACH 2 is targeted to care partners and caregivers, and so it's a very not different target, but many of the same goals that you'd expect. And they have developed 7 common components to what is described as REACH 2 and its adaptation. And I'll just read them: problem solving, skills training, stress management, support groups, provision of information, didactic instruction, and role playing. And again, this is a set of elements that are implementable. Next slide. In terms of effectiveness, as Rebecca said, there's definite evidence that this reduces caregiver depression and also caregiver strain, although the evidence is not nearly as strong. What's really interesting about REACH 2 and its adaptation is that it's been delivered in a wide range of real-world settings, and many of the studies in the real-world settings maybe didn't meet the criteria, but they did identify other aspects of benefit in addition to depression and strain, the reduction in challenging behaviors, level of caregiver frustration or bother, and physical symptoms. And another improvement is this self-reported social reporting and other self-reported aspects. The program clearly benefits the caregivers that are lucky enough to receive it. Next slide. Other factors are that it's gone from what we call efficacy testing and research to more implementation, and it's been studied across a quite diverse population. And as one who's done a lot of this reviews, this is unique to have this much diversity in terms of where a program has been tested in multiple settings, including socioeconomically diverse and racial, ethnically, and linguistically, geographically dispersed populations. It's being used at the VA, and many local Alzheimer's Association chapters are working on it. And again, it's a little bit is known, enough is known to know about resource requirements to begin to thinking about planning to use a program like this. Next slide. So the conclusions are shown on this slide. They do show a way forward, and these are the kind of recommendations or the basis for our recommendations. The fact that these two interventions produce low strength evidence, even if it's low strength, is important and does show a way forward. So notable trend in benefits across multiple outcomes, those for which the AHR peer review drew a conclusion, but also we found a consistency of evidence in other sources of benefit. And we do believe that there's enough known about equity, acceptability, feasibility, and resources to move forward. Next slide. Taken together, we think that this is sufficient to justify implementation. And this is the old way forward, which I've said probably too many times now, but still, it's approach that was likely to bring gains and better inform real-world implementation if we start to focus on additional trials and other ways of evaluating the effectiveness of this model. Next slide. I should say these models, because they're the two. So here are our recommendations. This is going to be broken up into 3 slides for each of the first 2 recommendations. So we recommend in the report that we implement and evaluate outcomes for collaborative care models in multiple and varied real-world settings under appropriate conditions for monitoring, quality improvement, and information sharing. It'll be important to examine key factors that determine whether and how to implement an intervention, and some of the needs that will determine whether something can be implemented, ranging from workforce and space to payment models and other policy areas that Robin alluded to in one of her slides. Next slide. It's also to advance these efforts, we call out the need, and we hope that the CMS will explore the value of these models through things like Medicare Advantage programs and alternative programs, alternative payment programs or models, and also the same with state Medicaid programs. Clearly, this is an area where states can take some lead in their Medicaid programs, and even consider whether there's a dementia-focused quality metric that they can use as a basis for working with collaborative care models. Next slide, please. And then on the research side, there are many players that can contribute. The NIA, which was a sponsor of this particular study, but also the Office of Planning and Evaluation in HHS, AHRQ, the Administration for Community Living, are all players who can look to these models and support research and stakeholder engagement. And likewise, the healthcare systems themselves, including those in the VA, should also consider and work with us to make these programs available and continuously evaluate them in a kind of a continuous quality improvement model. So now the next slide tells about recommendation number 2. And that's very similar. It just says, let's implement and evaluate outcomes for REACH 2 and its adaptation. And again, in multiple and very real world settings under appropriate conditions for monitoring, quality improvement, and information sharing. Here, again, we want to know what are the factors that are important in determining whether and how to implement an intervention. And here we talk about the same thing for collaborative care: workforce needs, payment models, and ability to implement these programs meeting the needs of different populations, which, as Rebecca mentioned, can be quite unique. Next slide. And similarly, the players here include a slightly different group. We think a CDC and the Administration for Community Living should incorporate REACH 2 into efforts to support evidence-based dementia programs at state and local public health departments. And again, look to CMS to explore the value of REACH 2 and see how that might be offered as a benefit for Medicare Advantage, and including in alternative payment models. And again, we look to CMS as probably being a major player in both programs when it comes to building infrastructure and training and seeing those programs emerge. Next slide. State Medicaid programs, again, have a stake here. We highlight the dementia-focused quality metric. We agreed to quality metrics to evaluate all these programs. And I know the Impact Collaboratory is starting to think about how to make progress there along with NIA. And in the NIA and the HHS Office of Planning and Evaluation, the HRQ, and Administration for Community Living are ways we think that we could find support for research and stakeholder engagement in these programs. Next slide. And again, the VA is a player here. And then where I live, healthcare systems should begin to think about how can we develop infrastructure that would facilitate the collaboration of providers of primary care, mental health, and other specialty care, and long-term care services that supports within the healthcare system and local communities to make sure there are agencies for implementing Reach 2 in these communities. Next slide. So with that, I've gone through a lot of slides in a hurry. I hope many of you will find these interesting, not just at this presentation, but if you have a chance to look at the report, because there's a lot more detail there. And with that, I am going to present the slide duty to Rebecca again. Rebecca, it's all yours.
Thank you, Eric. So having just heard about our findings regarding where the evidence base currently is, I'm going to talk a little bit about the work that we did to try to determine where the gaps and opportunities are so that we can really work on moving the evidence base forward and strengthening the evidence base. Firstly, it's really important to consider that while the AHRQ review found that there was insufficient evidence to support drawing conclusions about benefit for all of the other categories of interventions beyond Reach 2 and collaborative care models, that doesn't imply that those interventions are ineffective. So it really reflects the fact that there's an enormous heterogeneity, enormous complexity, as Robin was describing, in terms of this research area and the individuals under study and so on. So this is a very difficult area in which to conduct research. And as a result, the evidence base just does not yet support forming a firm conclusion regarding effectiveness of these other kinds of interventions. Next slide. So the approach that we took to determining where the gaps and opportunities in the evidence base were included taking a look at interventions where there was a signal of benefit. So we defined signal of benefit as interventions where across multiple independent RCTs, we saw an intervention indicating a positive effect, a positive benefit, even if when we looked at the overall body of evidence, there might be some mixed results. So some studies that weren't seeing an effect or some studies that couldn't come to a firm conclusion. But if we saw consistent suggestion of benefit, then that identified an area where we might want to look further, conduct additional research, and start to firm up the evidence base. We also conducted stakeholder input, information gathering meetings, including with persons living with dementia and their care partners and caregivers. We again consulted the best practice caregiving database, and we also drew on information from the National Research Summits on care services and supports for persons with dementia and their caregivers. Next slide. So I'm going to talk about a few of the gaps and opportunities that we identified through that process. The first is that while this is a very complex area and there are many different levels at which we could be targeting interventions, the vast majority of the evidence base is focused on interventions that target the individual level. So that means there's really an opportunity to expand the kinds of interventions that we're studying to look more closely at interventions at those higher levels, the community, policy, and societal levels. There are also a few interventions targeting direct care workers. And importantly, there's a lack of diversity in the populations that have been studied. Specifically, we need more research on a broader diversity of racial and ethnic subgroups, on LGBTQ populations, studies conducted in rural areas and in tribal populations. Next slide. We also identified that there are some intervention categories that are just very difficult to generate evidence for because of the inherent underlying complexity and heterogeneity. So there are some places where some interventions are going to work for some people and for some subgroups, and those same interventions just aren't going to work in other people and other subgroups. And for that type of intervention, it can be really difficult to generate a strong evidence base, because when we take a look at the RCTs, we're going to see mixed results across multiple studies, depending on which specific subgroup they happen to be focusing on. So for some types of interventions, like exercise and music, there's a very real possibility that they have important effects, but they're inherently just very difficult to study. Another significant gap relates to the quality of the evidence base. So one of the challenges that the AHRQ review identified is that there are many studies that are either quite small or of insufficiently long duration to really generate high quality evidence. So one clear gap and place where there's an opportunity to improve the evidence base is really raising the bar in terms of the methodological rigor with which some of these studies are conducted. Next slide. And so that brings me to our blueprint for future research. So the last few slides that we're going to be discussing will take us through our recommendations for improving the quality of the evidence base and moving us beyond some of these gaps that we identified. And our recommendation 3 is really focused on methodologies. So this recommendation is to use strong, pragmatic, and informative methodologies in our studies of these interventions. Here, we're specifically calling on NIA and other interested organizations to prioritize research that's conducted using the strongest, pragmatic, and most informative methodology. Some specific areas in which the methodology could be improved that we wanted to focus on include ensuring that the funder is funding a balanced portfolio of both short and longer term studies, and that those studies have sufficient sample size that we're able to generate evidence that we can really have confidence in. We also call on them to focus on a harmonized core of outcomes and a taxonomy of interventions, so that when we have multiple studies investigating similar interventions or targeting the same outcome, we're using the same set of measures and the same names for the interventions so that we can bring together and pool results across multiple studies. We also highlight the importance of focusing on outcomes that are prioritized by persons living with dementia and their care partners and caregivers. And relatedly, in studies using quantitative outcomes, also incorporating qualitative methodology. So as we've mentioned numerous times, this is a very complex area, and there are a lot of contextual factors that can make it difficult to interpret the results of studies. So bringing in that additional qualitative component allows us to generate richer information about the context. So when we see an intervention succeeding or failing, we can have a better understanding of why it is that it's working or not working. An additional significant challenge in this area is that it can be very difficult to conduct randomized trials in this context. And so using rigorous, high quality observational study methodology can really help to move the field forward more rapidly. And when we use really rigorous methods, even if the study is not randomized, we have the potential to generate high quality evidence. And then finally, committing to comprehensive study reporting so that we're sure that the evidence base is really reflecting everything that we've learned across these studies, particularly with respect to reporting negative results and unsuccessful methodological approaches. So when things aren't working, we know that they're not working, and we can build on that and use better approaches in future studies. Next slide. And here I will turn over to Xinxi to present our 4th recommendation.
Thank you, Rebecca. Again, thanks the National Academy and the committee and as well as the staff for supporting this important initiative. When we think about prioritizing inclusive research, I think a critical aspect of really strengthening the evidence base for care intervention for person with a dementia, care partners, caregiving, and ensure that research is representative, generalizable across the populations. I think study really needs to have a broad, inclusive research team equipped with knowledge, experience to study underrepresented population in different settings and develop and adhere to recruitment strategies and targets to increase the representation of, racially, ethnically, culturally, linguistically, sexually, socioeconomically diverse populations. I think strengthening this evidence holds the greatest potential to be able to improve health and well-being. Regarding the first bullet points in terms of conducting research using broadly inclusive research teams, having diverse multidisciplinary teams are really needed to ensure the team members are collectively have the insights into the sensitivity of different perspectives and cultures. I think resources also needed to be able to address those knowledge and readiness gaps between researchers, stakeholders within the community. I think researchers, sometimes do not know how to apply effective interventions to different populations and may not have addressed fundamental questions before attempting to do so. For example, some of the questions raised was, how did the researchers conceptualize the problem in the social context? Do they understand the social determinants of health? Do they have knowledge about the intersectionality and optimal recruitment strategies for specific populations? Do they really study both intended and unintended consequences and harms of intervention? As someone who studied a lot in the areas of elder abuse, neglect, and exploitation, those things are incredibly important. And I think before launching into a study, I think researchers also need to understand, person living in the community, as well as their history, culture, and resources. Understanding the readiness of the community and the community organization is really essential to be able to understand the community needs, as well as their culture, values, belief system, and what is important to them. In terms of second bullet points of includes the diverse participants to address health disparities and access outcomes. We know that U.S. population is growing rapidly, especially through the racial ethnic diversity lens. And it's also well known that racial ethnic minorities may have some higher prevalence and incidence of Alzheimer's disease and other dementias compared to non-Hispanic white groups, as well as the different caregiving patterns and use of formal as well as informal services. And yet often those populations are disproportionately excluded from dementia care research, as well as a low-income person with dementia, as well as care partners and caregivers. I think HRQ report highlights some of those limitations, observing that the very few studies actually examine those differences and that culturally sensitive and culturally, adapted interventions were really rare. I think to advance the field, we need to understand the culture aspect of dementia and caregiving. For example, in Chinese, the word dementia means crazy and catatonic. There's a lot of incredible cultural barriers that holds the greatest barriers for which medication and vaccine, and despite the effectiveness of potential intervention, addressing those root causes are really important. And I think to be able to make true progress, and I think, as you heard from our chair, NIH needs to be able to assume greater administrative accountability, ensure that increased representation of racial ethnic minorities in research studies. The NIH Revitalization Act of 1993 amends the Public Health Services Act to incorporate the mandate for inclusion of minorities in all NIH clinical research. However, those progress has been somewhat slow. I think to be able to close those gaps, retooling the workforce and then making sure that we understand the structure and system factors, barriers regarding recruitment approaches are critically important. The last bullet point in terms of using study design that supports inclusivity, I think to address those gaps, researchers need to use study design that allows for inclusivity, as well as increase the generalizability of study findings. RCT has tremendous promise, but also limitations. I think we need to think about incorporating other study designs, such as we talked earlier in terms of quasi-experimental design, longitudinal, well-designed observational studies, adaptive trial designs. I think it's necessary to be able to understand whether intervention can be effective in different subpopulations as well. And I think the Lancet report certainly have reported many risk factors associated with dementia surrounding inequalities that disproportionately affects minority and vulnerable populations. I think a lot more work needs to be done. Next slide. Recommendation 5, in terms of thinking about when the funding research on caregiving intervention for persons living with dementia, care partners and caregivers, NIH, HRQ, CMS, ACL, AOA, and other interest organizations should support research capable of providing evidence that will ultimately be needed to make inclusive decisions and implementation interventions in real-world settings. And to do so, I think, as we discussed earlier, the complementary study methodologies are really important to be able to focus on when is a pragmatic trial design perhaps be effective in real world. In some cases, pragmatic trials could be efficiently embedded into healthcare and other support delivery systems, such as electronic medical records for recruitments for specific racial, ethnic groups and vulnerable populations. However, there are limitations for those designs that needs to be realized. Observational study, where I do a lot of the work in terms of the values, the powers of doing a large longitudinal, carefully observed, detailed, assessed studies can give a lot of information, especially in terms of causality mechanisms. But those observational study have limitations as well. I think designing observational study with explicit goal of emulating a pragmatic trial, the target trial, those bias can potentially be reduced as well. When we think about community and policy level intervention, I think much of the focus of dementia research is being intervention to individual level. I think we really need to think about what are the larger interventions, perhaps for broader system, community, and policy levels are really important. Improving those evidence of the kind of intervention will necessitate taking the methodologies other than studying in individual populations. The last bullet point in terms of assessing real world effectiveness, as we discussed earlier, decision to implement interventions really much depends on not only the evidence of efficacy from control research studies, but the factors that influence the feasibility of implementation, such as workforce need, cost, alignment, work, and etc., which will influence interventions' effectiveness in real world settings. I think those considerations needs to incorporate into decision on whether intervention are ready to move into pragmatic trials or should be recommended for dissemination and implementation. And I think approach to address those gaps may include embedded trials, observational study that carried out in practice settings that implement intervention research of interest. So I think a lot more work needs to be done. And the last point regarding real world effectiveness is continue to leverage community-based participatory research or CBPR methodology into existing models and to be applied for research for person living with dementia, care partners, caregivers, including rural and remote dementia care programs. Next slide. I think final thoughts, providing collaborative care intervention and reach to for those who could benefit could represent real progress. However, there's an urgent need for more robust and useful evidence-based. Other interventions, especially those that are shown signal benefits, should continue to be developed. To quote Carl Sagan, the absence of evidence does not necessarily mean the evidence of absence. And I think this really reports opportunity to be able to push all of us in terms of advancing science and the meaningfulness of those science in community populations. And I think the opportunity to implement new methodologies, approaches in the field, especially through engaging early career researchers in building this more robust, useful, inclusive research base that will support the well-being of a person living with dementia and their care partners and caregivers. Next slide. I think the cover credit is a beautiful cover. It was reproduced permission from Leslie Narson, who's living with dementia in Seattle, Washington. You can see the full report online. And Claire Stroud, who's our fearless leader from our National Academy staff, has done a tremendous job. So let me pass back to our chair, Eric, please.
Thanks, Shin-Chi, and thanks to all the presenters, and thanks to the committee, and of course, Claire and the staff at the National Academies. I think we have some questions that are going to be teed up, and who's going to show me the question, or do I find it myself?
And sure thing, I will take care of that, and thank you all. Starting with a basic question, what is the difference between care partner, which we've heard a lot, and caregiver? Good
question. Robin, do you want to take that? I think you've talked about that a bit here and there.
I did talk about that a bit. I think that it focuses on the fact that it comes from the lived experience of persons living with dementia at certain times in their journey of living with dementia. They are really seeing themselves as partners in this journey, as opposed to having someone who's specifically a caregiver. And that is why we actually use the two terms, because they are related, but they're different. And, we spend a lot of time listening to people living with dementia. I don't think we do enough of that in establishing either our research questions, our methodologies, and even our outcomes. And the partner was really, the partner is there to suggest that this is truly a partnership. At some point, it may become more of a caregiving activity, but a lot of this has to do with the partnership.
Thank you. Our next question comes from William at North Carolina State University. And the question is, you've identified some promising paths for individual federal agencies, for example, the VA, Department of Health and Human Services, even the Department of Transportation. But do you have suggestions for integrating work across these agencies and other relevant ones?
Yeah, a very, very important question and a complicated one to answer. And maybe, again, I asked Shinchi and Robin to respond to that question. I don't know that we explicitly address it in the report, but I know we have ideas about it. Shinchi first and then Robin.
Sure, that's a great question. I don't have the answer for what you're seeking. I think there's a lot of opportunity out there, and I think this is where, not just in terms of collaborations, but also thinking about data set linkages in different settings. And could that be a platform where we can understand some of the research questions? But it's not without barriers, because each system, each organizations are inherently different with the different policies and rules. But I think there's a lot to be done. I think I'll let Robin perhaps address the second part.
As someone who did spend some time in the federal government and actually did work across agencies, it is extremely difficult, but not impossible. And some of this just has to do with leadership and commitment within the agencies to actually work together and try to figure out where there are joint win-wins in terms of both resources that can be used, questions that are going to be asked, and methodology and ways of getting to outcomes. The other I would say is that the Congress can be effective at also trying to move more interagency collaboration. And so, thinking about from our audience perspective, how do we push and advocate more for cross-agency activity where you can use both the resources, the brains, and the dissemination and translation functions to make this happen more. So it's absolutely possible. It's not easy.
Thanks.
Our next question is how can trials better capture the attention of payers? Or rather, how could real-world assessments better capture the attention of payers in terms of evaluating healthcare utilization outcomes, emergency department visits, or hospitalizations?
Try to take that. It's a very good question. It's an area that I think we need to continue to work on, but it's happening in places like the Common Fund Collaboratory and the Impact Collaboratory, where researchers and advocacy groups are starting to understand that you have to talk to payers if you want anything that you're planning to improve end up being implemented. And the magic is to understand each other's cultures, each other's reward systems, and understand what the priorities are and see where you can find a sweet spot to link up the priorities of the payers, the persons who are receiving the care they're paying for, and the persons who are delivering the care. And again, like Robin said about coordinating with federal agencies, it can be done. It's not easy, especially in a complicated system like our country has, but there are integrated delivery systems which are doing it. And groups like the VA, that's part of their DNA, is to try to figure out how does the payer, which is the public, and the VA work with its delivery system. So again, it's definitely possible. And I don't know, Rebecca, have you thought about that at all? Would you care to make a comment?
this is certainly not in what I feel is my area of expertise, but I will just say, similar to the comment from Robin about working together with persons living with dementia and care partners and caregivers in developing study questions, we really need to be working together with payers in developing study questions so that we make sure that the outcomes that we're investigating are the most relevant, so we aren't conducting studies that answer the wrong questions. Because if we really want them to be impactful, that's how we need to start.
Thanks.
Thank you. The next question is, we talk a lot about inclusivity in research. Should inclusivity among participants also account for the impact on individuals with disabilities, both as the client and as the caregiver?
Yeah, I'll take a stab at that. Yeah, we define inclusivity very broadly for the purpose of this report. And I think that those with disabilities certainly is a group that are often understudied and underserved as well. I think the onus is on us to be able to do more research inclusive of those populations to understand unique needs, because they're very different. Especially people with physical disability, mental disability, their needs are tremendously different. So it's a great point.
Yeah, and I think in the report, some of these ideas came from some stuff that Jason Karlowicz wrote first drafts of, this notion of there is a disability that is cognitive impairment. And just like a person who needs a wheelchair to ambulate needs a wheelchair. And we should think the same way about the disability of cognitive impairment. If we can substitute and provide a correction for that disability or a minimization of that disability, that's a key approach to providing a high quality dementia care.
Thank you. I know we're coming up at the top of the hour, want to be cognizant of time, so this will be our last question. And of course, we'd be remiss if we didn't acknowledge the impact of COVID. So this is a two-part question. COVID-19 has upended the quality of life for people living with dementia and their caregivers, and it'll also have implications for research, including challenges to study recruitment. So how can the research community continue to move the field forward post-COVID-19? And then how has or is COVID affecting the delivery of collaborative care or reach to?
That's a good question to close on. I think I'll just open the floor to all of the panelists to offer your perspective on that question, and maybe I'll say a thank you at the end.
Our CEO at Leading Age and myself had a conversation this morning with PCORI, which is actually another organization that we need to think about in terms of funding and research around COVID and some of the issues in the LTSS space. And truthfully, people living with dementia, their caregivers and partners have really been affected in very unique ways. I think in some ways it illuminates why we need more work done, particularly at the systems level, the policy level, and the societal level. And that is one of the things that I think that we could do post-COVID, is to really think about the interaction at those various levels, because that's what has broken down for people living with dementia and their dyad. And so really thinking about how we learn about interventions at these different levels and take that into post-COVID is, I think, going to be really important. I don't think we have had enough attention to these various diverse populations and the impact of something like a pandemic, a public health crisis. And I think we can learn a lot by looking more at some of these other levels.
Mm-hmm. I just echo what Robin said. I think, this is me wearing the hat as outside of the committee report, but as a geriatrician, that I see both end of the spectrum. I see patients who are elderly with dementia who are very much isolated in the current setting because they're not allowed to have family member visit them, either those in nursing homes, living facility, or living by themselves. On the other end, much of the care models are become very difficult to deliver. And for elderly who may live in a crowded houses where the conflict also occur, which exacerbates not only the disease and conditions perhaps, but also the caregiver-diet relationships. So I think it's very difficult. I think until we get to a point where we can achieve herd immunity, until we get to a point where the physical distancing becomes less, and so it will remain a challenge. I think all of us have to really leverage not only community services, faith-based organizations, and healthcare systems, and to really support elderly and their care partners and caregivers in need during those difficult times.
The one other thing that I would add is the panacea that everybody sees around technology is not questionable, but is raised in light of people living with dementia and their caregivers/partners. We need to better understand what the potential is for technology in mitigating some of these distancing issues, social isolation, and care delivery issues. And perhaps we have a lot to learn from that post-COVID, for example, in rural and frontier areas where we are never doing a great job at actually reaching these populations, or in diverse populations. So I think we have a lot to learn, both the good and the bad of the potential for technology to be a mitigating factor in addressing some of these issues.
I completely agree with Robin, and I have a bit more of the research perspective as opposed to the interventional perspective. And I can say it's been amazing to watch the disruption of the clinical research enterprise that has resulted from COVID-19, but also how rapidly we've adapted to it and tried to come up with alternative ways to continue to move forward with our research, sometimes by developing new technological tools or harnessing things like telemedicine that have been around. It's not a new idea, but suddenly we're like, oh, okay, we can't do our study by doing an in-person visit. How can we adapt and do this in another way? And I think what we're starting to realize is we could take that and use that to deliver interventions to people in rural settings, in other contexts. So I think we are learning things from COVID-19 that will allow us to conduct research in more efficient, maybe more clever ways in the future. And I also think it goes back to leveraging study designs beyond just RCTs. If it's going to be impossible to enroll people in a clinical trial because we can't do face-to-face interactions, that doesn't mean there isn't still a wealth of data that's being collected through our healthcare systems, and that we could be thinking about smart ways to harness to answer some of these questions without having to do direct face-to-face interactions.
And I just might add, I think it's probably self-evident that the pandemic has just exposed the huge disparities, and nowhere is that more evident than I think in the way people living with dementia receive their care, so that those people who have the least essentially don't get anything like the kind of care they need. And it's exacerbated our disparities, not just in dementia care, but also in mortality overall. And I don't want to end on that note, though, because this committee started well before the pandemic. And the bottom line for our report is really a way forward. I've been on quite a number actually, of National Academy reports from the Institute of Medicine days to the present. And I think this report has a potential to be catalytic in terms of catalyzing change and improvement for the future. And I hope all of you listening and those who will hear us recording or read the report can see this as a way forward. And lastly, but by no means least, on behalf of the committee, I want to recognize the National Institute on Aging for their support of this exercise, and also Claire Stroud and the team at the National Academies. I think each member of the committee cannot have been happier with the kind of support and creativity we received from the team at the National Academy. So with that, I will stop speaking and turn it back to Stephanie, who I think will do the benediction here.
Thank you all. You'll be redirected to our report page anyhow once you exit this webinar, but the link to download the report, the press release, the summary, all the materials, it's bit.ly.com/dementia care study. And again, you'll be taken there once you exit this webinar, and the slides will be posted on that page in the next few days. Once again, I want to thank all of our committee members for joining us today, and thank you all for joining us. Have a wonderful rest of your day.
Bye-bye. Thanks.
Bye-bye. Take care.
Thank you.